Good afternoon, everybody. Thanks so much for your attention. Disclosure slide, always appropriate before we go on. So I'm going to talk a little bit about something I think as a cardiologist, and I recognize my audience. So if you have rotten fruit, go ahead and throw it now, and we'll get it out of the way. But I'll talk about something to start that hopefully we can agree on, and looking at hypertension and an area of significant overlap between our specialties. So this was a major issue for me, and when I came up through my training, just understanding like how far off we were of our goals to getting people to blood pressure targets was astounding to me. So, data that I think is familiar to many in the room, but a very common disease state, the most common disease state in the United States. About half of the individuals over age 18 with hypertension. Cholesterol, again, very common, above the average cholesterol in adults 20 years and older is 191 milligrams per deciliter. That is significantly above what our targets, the ACC-AHA, would like for them to be. And undertreatment of hypertension and hyperlipidemia, even though in this day and age most of these drugs are generic, is a common clinical problem. And when we look at this as an evidence gap and an implementation gap, 30 to 50% of patients don't get optimal medical treatment for these chronic conditions, even though, again, these treatments are often generic. So what we had looked at was, well, let's look at this from a first principle stance. Why is this such a challenge? And I think if we look at the traditional care model on the right, where there's one clinician who's in charge of a panel of patients, that's the model that we've used since kind of the good old days. It doesn't scale very well. We've tried expanding medical schools, we've tried bringing in APPs and physician extenders to try to increase access and make it easier for patients to receive healthcare and for providers to provide it. But it's gotten a lot more complex. We were talking about the advent of so many new therapies in the nephrology space over the past decade. That's incredible. Cardiology, similarly, has seen the number of available medications to treat our conditions almost triple in the past 10 years, which is a great part of being a physician. This is a golden age of being a healthcare provider, such that we can provide so many new treatments to our patients, but it's getting more complicated, it's getting more challenging, and it's getting more difficult to get each patient to their targets based on guidelines. And so what we've done at Mass General Brigham is create a team-based approach where we pull together physicians, what we call patient navigators, and pharmacists, and use technology to help make it easier both for providers to deliver medical care and for patients to receive it. So we do things like remote physiologic monitoring, lab data, and omnichannel communication, so text message, email, phone calls, not just secure patient gateway, which has all sorts of issues with equity and access, bidirectional communication, as well as integration with the electronic health record to make it a much more comprehensive and single-stop shop for patients and providers to receive and deliver healthcare. This team can then prescribe and titrate therapy, monitor that medical therapy remotely, communicate with our patients in ways that they're more familiar and comfortable communicating, and do that in a high-touch manner. It doesn't mean they have to come into my visit, sometimes drive 30 minutes, take another 30 minutes to park, pay for parking, sit in the office for 30 minutes before they see me for 5 to 10 minutes, and then wait another 6 months to see me again. It doesn't make a lot of sense, and patients are not happy with it by and large, which is why I think we're trying to change the model here. We do provide this in evidence-based clinical algorithms that are backed by the major society guidelines and provided multi-language support. Talking a little bit about these roles, our patient navigators were non-licensed, but part of that high contact model, leveraging some of these new tools like AI, they can even scale that process much more than they had in the study that I'll share in a few moments. Our pharmacists are actually allowed to prescribe and up-titrate as well as discontinue medications under collaborative drug therapy management programs. So for my clinicians in the room, the Coumadin Clinic, you set it and forget it, you let the team take care of it. We're able to do that for much more complex disease states. We've done it now for hypertension, hyperlipidemia, obesity, diabetes, and even heart failure. So really making that a major rate limiter that's taken away by using these pharmacists kind of at the top of their license through these algorithms. So we published a study of about 10,000 patients across Mass General Brigham where we had a remote data-integrated blood pressure program where we would send them a blood pressure cuff If they were referred by their physician or found to be above goal from some of our population health efforts. And what we did was we had what was a qualifying blood pressure. That's what got them into the program that we took in clinic. A home baseline blood pressure, which is once you get them the blood pressure at home, you teach them how to use it appropriately. Here's a week's worth of average blood pressures. This is what it looks like at home. And here's a maintenance blood pressure. And this is what we as a team were able to achieve after making medication titrations. Again, no visits, totally remotely, asynchronously with a pharmacist in the lead, always backed up by a physician, but doing this in a team-based approach. And what we showed across these stages of the program is both in qualifying to baseline as well as through maintenance, significant systolic blood pressure reductions by participating in the program. That was recapitulated across an equity lens, looking at groups that are traditionally underserved in medicine, with similar results without any significant difference across those groups that are traditionally not as well served. We saw something similar in cholesterol. So looking again at our overall population of cholesterol, these were following ACC/AHA guidelines on who deserves cholesterol-lowering medications or would have an indication for one. Again, looking at effectively a halving of serum LDL cholesterol. So starting with 140 milligrams per deciliter, dropping that down to about 70 milligrams per deciliter by the end of our programs. And then looking at, again, with an equity lens on the right, significant and sustained reductions across those groups that are traditionally underserved. So we were pretty excited about this. How did we do this? Looking at the lipid data, this was largely just taking patients who were not on therapy, who had a guideline indication to be on it, and getting them on therapy. The vast majority of those being a high-intensity statin, also increasing the use of ezetimibe, and to a small degree PCSK9 inhibitors for those who did have indications. But this was mostly achieved through medication changes that we were able to complete remotely. This was published in JAMA Cardiology as a 10,000 patient trial that we were able to get many of these people to goal in kind of a scalable remote process. This is some of the data, and you'll see some faces pop up in the end. I always like to give some of the fellows that work on these projects some credit. So this is one of my fellows, Shahzad Hassan, who's now down in Miami. But this is looking at, how well does this look in the long term? And this is the follow-up for looking at the bottom of the graph here. This is time since randomization in months. So 3 years after their participation in the program, what happens to the people that participate? Whether they take education only, they don't actually accept any medication changes, if they enrolled and exit early, or if they enroll and complete the whole program. That's the green. The enrolled and exit early is in the red. And the white coat hypertension, interestingly, is in the orange in the bottom left. So if you look at these patients 3 years out in data in the EHR, they're actually able to get to their goal, again, within 6 months of participating in the program, and they stay there out to 3 years. We don't intervene in any way, shape, or form after they complete the program. So 6 months after they touch us, they're done. But even 2.5 years later, they're still at those goals. The people who have white coat hypertension, their blood pressure, unfortunately, continues to move in the wrong direction. Wish we would have gotten them when we had the opportunity, but their blood pressure is unfortunately getting above goal. But this just shows that this is a sustained result, that we don't have to continue to manage them or meaningfully change many of their medications. Once we get them there, they can stay there in the long term. And again, after achieving blood pressure goals, 90% of the participants sustained a blood pressure less than 140 milligrams mercury systolic up to 42 months post-enrollment. So again, this intensive program does lead to sustained results. This is our hyperlipidemia, and again, one of my fellows at the top right, showing it again across the indications for hyperlipidemia management, ASCVD, hyperlipidemia, diabetes, and primary prevention. The vast majority of people are maintaining those reductions in their cholesterol levels up to a year post-enrollment. So significant and durable results that we're excited to show. So we've published, and I mentioned, the same team-based approach across diabetes, across hypertension, across heart failure, obesity. We've actually got a program in kidney disease that we're kicking up here now at Mass General Brigham, because I think that getting people to goal and helping them achieve these long-term results is really important for systems and not just for individual patients. So where does AI come into this picture? So we run a lot of these as clinical trials, and being able to identify the appropriate patients for clinical trials is actually a major hurdle for us. Looking at all the inclusion and exclusion criteria for a trial are often now sometimes 60 criteria long. And as we roll these programs out from a trial to clinical implementation, that's a big part of the effort, going through who's actually eligible for the program, who would benefit, and how much benefit are they likely to derive by participating in the program. The challenge is because of a lot of what we do as clinicians. If I want to order a stress test as a cardiologist, I generally have to put a code and justify that to our lovely payers of why I'm ordering a stress test. There is no code for, I think this person might have coronary disease. The code is coronary disease. Otherwise, it doesn't get covered by insurance, and my patient comes back yelling at me because they have to pay for a very expensive stress test that they thought they deserved, and I did too. So unfortunately, the structured data world that we live in is conformed and built to adhere to a set of quality and payment characteristics that have very little to do with clinical care. That is a small example of a huge problem in the structured data environment that we currently live in. And so anytime I'm looking for people with coronary artery disease, about a third to a half of them actually don't have coronary disease. Somebody coded that because they were getting an EKG, or they were getting a stress test, they were putting them on a statin, and they thought they might have coronary disease or have high risk for coronary disease, but they needed to justify it. And the justification that gets paid for by our lovely friends in the payer world are the codes that they can justify that payment with. So that makes our job as clinical trialists very hard, because I have to have my very talented, lovely, amazing clinical trial study staff click through a lot of charts to find people that meet all of those inclusion criteria, that don't meet any of those exclusion criteria, and are actually eligible for the study. In fact, good data out there that shows that 80% of the people that we get screened for a trial are actually not eligible for the trial. And the only way to find that out is by clicking into those charts and one at a time assessing, is this person eligible or are they not? So we created a system at Mass General Brigham using an AI tool that we called Rectifier. And two major things that we had to customize with this system. The left panel is the structure of the system. We use a technique called retrieval augmented generation. Essentially, it allows to solve two major problems with large language models. One is something called a content window. Essentially, how much data can you feed into that AI model that it then is able to process to ask and answer questions about. Every model is finite. Some are smaller, some are larger, but medical data is extremely voluminous. So you need to be able to process a ton of data to be able to answer questions about clinical trial eligibility well. The other challenge with large language models is cost. And even though the costs are being driven down, being able to ask a ton of questions about a lot of medical data gets expensive very quickly. Retrieval augmented generation could actually solve that, and I'll talk about why in a few slides. The more important question is, well, does this even work? And so we designed a study that we published in the New England Journal AI, where we essentially took a cardiologist who'd reviewed a few thousand patients that we'd assessed for a clinical trial, looking at their eligibility, both inclusion and exclusion criteria, and said, okay, that's the gold standard. Our cardiologist should really know, is this person eligible or are they not? We're going to pit those answers against our clinical trial study staff, we show here in blue, and Rectifier, which is our AI model that we show in red. The AI model outperformed our study staff across specificity, accuracy, and Matthews correlation coefficient. It was also more sensitive, although it didn't quite meet statistical significance. This is the large language model content window issue that is, again, solved with retrieval augmented generation, just looking at somewhere between 25 and 95% of patients would overstuff that model. The good old adage in medical data sciences, garbage in, garbage out. If I can't even fit all the data in, I'm not going to get a good output on the other side of that, so we had to solve that first. The other challenge, again, you got to love the New England Journal, supplementary table 10B here for you, is costs. Again, we have to really make this something that's economic and sustainable. I can't be spending hundreds of dollars per patient and make that say, hoo-hoo, I won, it's feasible. This doesn't scale well until you can really get it down to a cost of a few dollars per patient, which we were able to do with this technique. So that's great. I'm at Brigham and Women's Hospital, and you're not cool at Brigham and Women's Hospital unless you do a prospective blinded randomized controlled trial. So retrospective data is fun, but prospective data is necessary. So we designed and conducted a prospective blinded trial called the MAPS LLM trial. This was presented as a late-breaking clinical trial at the American Heart Association last year. And what we did was the same process. We said, okay, this should work. We've got good retrospective data. In theory, it makes sense. We're going to then randomize at the point where we would normally ask our study staff to open a chart and say, are they eligible or are they not? And we're going to see if we can get some differential results. We looked at eligibility determination and a hierarchical win ratio, prioritizing enrollments with pre-specified exploratory outcomes of enrollments and equity. They had the same amount of time for both groups. We flip-flopped groups throughout the course of the trial to make it as fair as we could, and we blinded the study staff. So once they were screened, it was a different study staff who called them to see if they were actually eligible for or would enroll in the trial or not. Consort diagram started with 200,000 patients who'd had an echo in our system in the past 2 years. Structured data can take a lot of that out. It's important, it's necessary, it's a great starting point. But 4,500 people is a lot of people to still run through, and we randomized them then one at a time into AI-enabled or the manual screening process. Table 1 is a randomized trial, so you would expect this, but it's balanced across age, sex, ethnicity, race, area deprivation index, and type of heart failure. We published this in the main JAMA journal earlier this year, and so AI is in blue and manual is in orange. You can see AI is significantly faster. At 10 days from randomization, AI is essentially done with all the screening. Again, this is a human-in-the-loop process. Humans still had to validate. The AI system just brought the data to the fore so that they could do it much more quickly and efficiently. At 10 days, AI is done with 20%. At 10 days, manual is not quite done to 2.5%. So, a significant increase in efficiency of finding those eligible patients. By protocol, I'll show our pre-specified secondary outcome. This was a hierarchical win ratio. It was positive. Each individual endpoint was independently, statistically significantly positive. It's not a beautiful figure because JAMA published our pre-specified exploratory outcome of enrollments head-to-head. And what you see here is just about a doubling of enrollments in this prospective blinded randomized controlled trial with a p-value 0.04. So we can now use this AI tool and are using this AI tool to enhance and accelerate clinical trial enrollments at our institution and elsewhere. Quick conclusion, AI-assisted patient screening using Rectifier improved eligibility determination enrollment in a heart failure clinical trial as the use case. Rectifier can enhance clinical trial efficiency, reduce resource utilization, and promote equitable recruitment, potentially lead to faster trial completion and patient access to novel therapies. And generative AI is likely to play a significant role in the future of clinical trials as well as clinical care. Thank you very much for your time and attention.